Hello, and welcome to Making the Rounds, a podcast by the American Medical Association. Today's episode is part of our Health IT series from the AMA Medical Student Section Committee on Health Information and Technology. My name is Kristofer Jackson. I'm your host for today and a medical student at the University of Toledo, College of Medicine. Today's guest is Dr. Edward Melnick, an associate professor of emergency medicine and biostatistics at Yale. Dr. Melnick's research focuses on improving EHR usability to improve healthcare quality and delivery. Thanks for being with us today, Dr. Melnick.
Yeah, thanks for the invitation. Happy to join and be a part of your group.
So how are you involved in the health IT space, and what are you currently working
on? So a lot. I guess the broad summary is really that my research program focuses on using research as a tool to improve digital health user experience. So broadly, that can be for patients or other members of the care team. As an emergency physician at Yale, I use the EHR in my clinical practice. So a lot of what I do is informed by what that experience is like. But specifically, I focus in three broad categories. So design, evaluation, and measurement. So historically, my research had been more in the design space, trying to understand challenges to following best practices in evidence-based medicine and building more user-friendly interventions to help with adoption of best practices in actual routine clinical care. So in that's kind of the first piece, then also evaluation of interventions that we've built. And then the third piece is measurement. So actually measuring more broadly how people interact with digital health, but more specifically the EHR. So what I'm working on right now in that space, we actually just wrapped up a large clinical trial evaluating a user-centered clinical decision support tool to facilitate adoption of medication treatment for addiction in the emergency department. So treating patients with opioid use disorder with buprenorphine is pretty new to a lot of emergency providers. So we built some resources for them and rolled them out across 5 healthcare systems and have just completed a large trial studying that. We're analyzing the results of that now. So that's the design and evaluation pieces that are active. And then in the EHR use measurement space, I'm very interested in just how we can quantify what that experience is with the EHR and show where there are gaps, and then use that empirical data to close those gaps. So I've am now transitioning from 2 old AMA practice transformation initiatives to a new one. And the first 2 were about standardized measurement of EHR use in ambulatory care and analysis of EHR use and how it relates to physician turnover. So we're launching a third project now that dives a little deeper into that. So that's the research, and then also oversee a clinical informatics fellowship program, which is a pathway to board certification in clinical informatics. And we take 1 fellow each year for a 2-year program and try to give them a broad introduction to the field of clinical informatics. But when they work with me, kind of focusing on those areas in terms of the front end of health IT and what that user experience is and how to improve usability for patients and clinicians taking care of them.
Okay. And we kind of already got into this, but what do you see as the impact of your work, and what do you hope will be the impact of your work?
Yeah, I mean, I'd really like to shift what that user experience is like, right? So there's quite a bit of frustration with current interface and workflows of the EHR, and how can we use research as a lever to draw attention to that and make improvements. And so for like the design, often it's a single clinical decision where we're trying to figure out what would work best here. For measurement, it's more broadly where are the gaps, how can we close them?
Okay. And I know it's a favorite of everyone in the medical profession is to talk trash about the EHR. It's one of the great talking points, but what is something that they do well that we don't commonly think about or that we don't commonly see day to day? What's something that the EHRs actually help streamline as they are currently?
Yeah, so I mean, there's definitely frustrations with use, but in terms of what's happened in healthcare in the last decade or even 2 decades, we've undergone a real computerization that's been quite rapid. And so some of the things that we take for granted are what it really means to have a functional and reliable system as the backbone across large healthcare systems, right? So the ability to collect, store, share data and information about patients, although it's fragmented and we still have a ways to go in terms of interoperability across systems, is still really powerful. So that's, I think, probably the biggest win. The safety side of things, also there's different schools of thoughts. There's probably major advantages in terms of patient safety for how the computer can act as a safety net. That said, there's also been unintended consequences and new safety challenges as a result of some of the troubles with the system. But I would put it broadly in those 3 categories. To have functional, reliable systems across large networks with the ability to share data, and then to prevent medical errors more broadly, often related to medication administration, although there, again, are unintended consequences.
Yeah, I went with my dad to the doctor yesterday, and his doctor still uses paper charts, and I was blown away. Like they still make those.
It's very rare. First time I've heard about it in a while, but we're definitely not at 100%, although we're certainly close, and we've come a long way, again, in the last 10, 15 years.
Yeah. How has COVID affected your work, and what changes have you seen?
Yeah, well, I mean, my academic work is almost entirely remote now. The clinical space, of course, in the emergency department changed pretty rapidly to accommodate COVID patients. And now that we're much later and hopefully towards the tail end of the pandemic, we're potentially coming closer to normal. Our patient volumes dropped considerably. And just because we had fewer patients coming in, some of them were actually more sick, and just due to trying to figure out where patients go and what the processes look like, at least locally at Yale, I think we're still undergoing a lot of strain in terms of patients that are boarding in the emergency department. On the academic side, though, in terms of COVID and being at this once in a century time for the research piece. Actually, the trial I mentioned to you, we leveraged a lot of our infrastructure to pull data on trends related to COVID. So tried to do our part to helping understand what was happening, often related to these trends, across our trial network. And then, I mean, I guess as an educator, also, we're just in, as a medical student, I'm sure you appreciate this, a more challenging time in terms of what it means to teach and to learn when a lot has shifted remotely. So I actually taught a course in our School of Public Health on clinical decision support this spring, which we designed to be very interactive, and we taught it entirely remotely. And it actually ended up going okay in terms of ways to engage the group. Definitely would have looked a lot different in person, though.
What do you see as the tech changes that we've implemented during COVID? What do you think is going to stay? What do you think has staying power?
Yeah, well, definitely the telehealth boom is here to stay to some degree. Early on in the pandemic, I think we thought it was going to be bigger than may end up being. There's still a lot of clinical care that you just can't deliver remotely, and a lot of patients that want face-to-face. That said, there are other things that you really don't need to do face-to-face, and some of the burden of being a patient and making it to the doctor for something that can be managed by an email or a phone call. I think that transition has started to occur and will likely stay to some degree. I think there's going to the pendulum's probably going to swing back and forth a little bit until we figure out what it means exactly. With our AMA work, we looked at a lot of inbox messaging that occurred across ambulatory practices at Yale New Haven, and some of that burden, although it's been taken off the shoulders of patients, which is important, gets transferred to the clinicians and their team in terms of how to triage messages and address messages. So one thing that helps in this space is at least formal telehealth appointments. There was a shift in reimbursement, and when reimbursement changes, I think delivery kind of follows suit. So certainly for the appointments that we can do over telehealth that are covered by insurance, that's a win. And again, it'll settle out, I think, eventually what should or should not be in person. The messaging is still something that is a win for patients, but for clinicians, it's something that I think will continue to be worked out in terms of whose role it is and how best to make the process to answer patients' questions quickly, but in a way that is not overwhelming to their doctors.
And in about 10 or 15 years, when we're all practicing physicians and the people listening to this are hopefully practicing physicians, what do you think are going to be the challenges that we're going to be facing in health IT, and what will have changed at that point?
Yeah, I think future gets a little murky more than 5 years out, because we could go in a lot of different directions, and who knows what other emerging technologies will arrive and disrupt how we deliver care. Looking more in the next 5 years, though, that one of the big changes, I think, is as part of the 21st Century Cures Act, there's a lot more interoperability and ability to build essentially apps on top of the EHR. So we're already starting to see these third-party software platforms disrupting the space and actually building things that work better for doctors and patients. So I think that we may begin as a result of that to see the EHR vendors more as the operating system. So if you think of the App Store on your smartphone, the Android or the Apple piece is what's running in the background, and then you download your apps. So I don't think it'll be quite that equivalent, but there will definitely be third-party things running on top of the EHR that streamline the process for a lot of routine clinical workflows within different specialties, and each one really requires a lot of thought and careful design based on whatever the clinical evidence is or what the clinical processes are around it. And I think it's really interesting to think what can be done in a really centralized way about that, and then how much of that actually becomes also like a local practice pattern. So I think the most nimble third-party apps in that space will probably be understanding of both possibilities. Can we build something that is universal versus can we build something that really meets local practice needs? So there's that, in terms of really the next 5 years. And my hope is that the EHR use measurement space draws attention and we start to, again, kind of close gaps and that there's more of a push for more usable technology in general. And you can definitely have disruption in this space. A lot of it relates to billing. So how do you actually check boxes, for example, to drop a charge on a chart? Some of that has changed actually just this year in ambulatory care. That's a big win for doctors in terms of the burden of EHR use. It's kind of unrelated to the technology itself. But as we move in this direction, I think there's going to be a lot of push and pull until we figure out, what works and what doesn't, and how much does the government want to get behind particular pieces. What we've seen though in other industries is that over time, usability goes from something that's unrecognized to something that's appreciated, and really just becomes baked into the strategy of an institution or a company. So my dream and what I think may happen in more like 10 or 15 years is that we actually have designers and usability and human factors engineers really thinking about this, for the end-to-end user experience of what's it like to be a patient from the time you think about an appointment till you arrange the appointment, go to the appointment, come home, and what comes after. And then for the clinician, what's it like to log into the system, take care of a patient, go to the next patient. There's a lot of meta level pieces on that too. Like in the emergency department where I practice, we're managing multiple patients at the same time. They're coming and going, and acuity levels are changing. So really understanding that and building systems that support that, as opposed to potentially get in the way of it.
And as we wrap up here, Dr. Melnick, are there any ways or avenues that you want students or people who are listening to be able to reach out to you and follow your work?
Yeah, I'm on Twitter, I guess. That's where I often will post new papers. When I have something big, usually I try to get it through Yale News. So that's, a good platform. I tend to follow just like the table of contents on like the JAMA journals and JAMIA, that's the American Medical Informatics Association. And that way you see like new articles as they come out. Some are mine, some are not. And it's funny, like, once you're on Twitter for a while, often you find that group of people in your space, and sometimes you're seeing the articles there before they make it even to the table of contents.
This has been Making the Rounds, a podcast by the American Medical Association. You can subscribe to Making the Rounds and other great AMA podcasts wherever you listen to yours, or visit ama-assn.org/podcast. Thank you for listening, and goodbye.